Hello, everyone. Welcome to the fifth meeting of the COVID-19 Health Equity Task Force. I am Captain Samuel Wu, and I am the designated federal officer for the task force. I would like to wish everyone a happy Pride Month. Also, this month is historic as we commemorate the first Juneteenth. The focus of today's meeting is on the inequities and the impact of long COVID, also known as post-acute sequelae of SARS-CoV-2 infection, and the access to personal protection equipment, testing, and therapeutics that are related to this pandemic. We will hear from two distinguished speakers, followed by the presentation of the task force members on their interim recommendations. As a reminder, this meeting is being live streamed and recorded and will be available for viewing at a later time. All materials presented in this meeting will be available on the task force website at minorityhealth.hhs.gov/Health Equity Task Force. We are providing American Sign Language interpretation for those with hearing impairment. Closed captioning for this event is available at both the HHS live streaming channel and the Office of Minority Health YouTube channel. Members of the public have been invited to provide comments as stated in the meeting notice published in the Federal Register. Written comments will be accepted up to 7 days after the meeting. Please send comments to COVID-19 HETF at hhs.gov. With that, I turn it over to Dr. Marcela Nunes-Smith, Chair of the Task Force. Madam Chair, the floor is yours.
Thank you so much, Captain Wu, and welcome everybody. This is our fifth public meeting of the Federal COVID-19 Health Equity Task Force. Thank you for joining us. The task force is charged to provide recommendations for mitigating health disparities caused or exacerbated by the COVID-19 pandemic and preventing such inequities in the future. From the beginning of the administration's response, equity has been front and center, and this has meant foregrounding equity and access in every aspect of the national plan. The task force is also charged with considering guidance specific to culturally responsive best practices, language, access, and sensitivity towards Asian Americans, Native Hawaiians, and Pacific Islanders, and the federal government's COVID-19 response. So the administration has made notable progress in distributing vaccines around the country, including to the communities that most urgently need them. 65% of all adults have received at least one shot, including 87% of seniors. And we're seeing all around us hopeful signs in terms of trends in hospitalizations and deaths, particularly among older people in the country. 70% of adults over 30 have already received at least one shot. By the 4th of July, this will also be true for those over 27 years of age. There is absolutely more work to do connecting with people who are ages 18 to 26 years of age, and of course, those who are medically underserved to increase vaccination uptake in those groups. The reality is those individuals who are unvaccinated, regardless of age, remain at risk for COVID-19. And those communities with low vaccination uptake rates also remain at risk for localized surges. Vaccinations save lives. And for those people who are still deliberating, the Delta variant, a recognized variant of concern, should be a compelling motivator. This variant is highly contagious, has the potential to cause more severe disease, and is on track to become the dominant variant here in the US. Regardless of the variant, and very relevant to today's meeting, avoiding post-COVID syndromes or long COVID is yet another. And even as vaccination remains top of mind in the country and all around the globe, we must still prioritize equitable access to PPE, testing, and therapies. And in this Pride Month, we continue to elevate the importance of intersectionality and of intersectional and disaggregated data in understanding who is at greatest risk and where resources and interventions should be targeted. And as we hold our work as a task force, we take the necessary broad lens to center equity across the groups that are most affected: people with disabilities, those who are justice involved, older Americans, rural neighbors, mixed status families, people of color, indigenous people, those living on the margins of the economy, those who identify as LGBTQAI+, and others. So over these past few months, the task force has shared with you interim recommendations specific to several key areas: the data necessary to drive an equitable response recovery, equitable vaccine access and acceptance, behavioral health, discrimination, and xenophobia. And today we are turning our attention to two important priorities. First, equitable access to PPE, testing, and therapies. And second, post-COVID syndromes, also known as post-acute sequelae of SARS-CoV-2 infection, or long haulers, or long COVID, as we will primarily refer to it as today. But first, on PPE testing and therapies, as a practicing physician myself, I'm all too aware of the challenges faced by healthcare workers and other frontline essential workers in accessing the necessary and appropriate PPE, especially during the height of the pandemic. There are many lessons to be learned here that will be relevant in future preparedness. And importantly, the administration has rallied on many fronts to secure PPE and clarify the relevant guidances, also making sure people need not worry about cost associated with purchasing protective masks, specifically sending millions of masks to federally qualified community health centers across the country. But there are lessons we need to learn as well regarding testing and equitable access to testing. In the very first stages of the pandemic, testing sites were disproportionately located in predominantly white, high socioeconomic status communities. Many testing sites were also drive-up only, with narrow windows of availability, virtually removing access to lower income people, workers' families, and those without vehicles. And as new testing technologies emerge, guaranteeing equitable access will be key. The data also demonstrate differential access and uptake in terms of COVID-19 therapies. And it's an imperative that everyone have access to the scientific discovery that we all should benefit from, including on the testing and therapeutic fronts. And the administration has made significant and substantial resource investment to advance equity in both COVID-19 testing and therapies. Still, and especially as the country reopens, pockets of lagging vaccination uptake remain, and the risk of localized surges remain. So recommendations regarding equitable access to PPE testing and therapies are vitally important. And today we are also talking about long COVID. We are still learning about the effects, mental, physical, social, and emotional, often compounded by grief and bereavement. There has been limited research to date on post-COVID conditions and insufficient data to even accurately estimate the number of people who are affected. The CDC is working very closely with government, local government, academic, community partners to better understand the long-term effects of COVID-19. Updating clinical guidance to providers is absolutely fundamental. Research is a must. The NIH Recover initiative is funding research concerning the risk, what contributes to long COVID, as well as strategies for treatment and for prevention. In these weeks and months, we've also been listening to and learning from community members about the long-term effects of COVID-19 on their lives. Many people with long COVID symptoms have felt alone and isolated in their suffering, without adequate recognition from the medical community or sufficient access to assistance programs. So one key task at today's meeting is to better understand the potential for inequities and the burden of long COVID, and in access to state-of-the-art care, and to provide interim recommendations for mitigating these inequities. In addition to problems with diagnosis and care, we know the issues facing those suffering from long COVID symptoms are multifactorial. Housing, as well as financial, nutritional, employment insecurity, of course, will have a profound impact on anyone's ability to heal and move forward. And those who are under the chronic stress of poverty, who have already been severely affected by this pandemic, will continue to need proactive support to achieve wellness. And as we anchor our work as a task force, we are especially mindful of the scores of families and communities across the country who are grieving the loss of loved ones to this pandemic, for whom a return to an old normal just is impossible. We also recognize the grief gap. Loss has fallen upon the most marginalized communities, and the mental health, behavioral health issues will need ongoing attention. So we have to strive towards a new post-pandemic reality and not return to our normal policies and practices, whether it be in housing or education or healthcare, employment and beyond, because those have failed too many and have made minoritized and marginalized communities the most vulnerable to all of the tragedies of COVID-19. And in order to honor the lives we have lost, we must continue to not only center equity in our response and our recovery from this pandemic, but also work to address those root causes of health disparities in the country. And the Juneteenth National Observation reminds us of the urgency of this work. So today we will deliberate interim recommendations that may be modified ahead of the final report. Thank you in advance to our guest experts. You will hear from them in the first half of the meeting. And as always, to the task force subcommittees for just another tremendous sprint this month. As a reminder, the work of the task force is organized across 4 subcommittees: communications and collaborations, data analytics and research, healthcare access and quality, and structural drivers and xenophobia. Each of the 4 task force subcommittees will share interim recommendations for group consideration ahead of public comment. And we will then deliberate further as needed ahead of voting in the second half of the meeting. I also want to extend my deep appreciation to the federal staff team, all of the members. Your commitment to the work is inspiring. And thank you as well to the many subject matter experts who met with the task force over these past weeks to help inform the work. And to the many people who have joined me in stakeholder roundtables to share additional insights and perspectives. So looking forward to another really great meeting. Thank you so much for joining and for your time and attention. Now I'll turn it back over to you for the roll call, Captain Wu.
Thank you, Madam Chair. Now I will conduct a member roll call. This is for the meeting record. When I call your name, you may respond with present. Okay. Ms. Mara Alvarez.
Present.
Dr. Sarah Blige.
Present.
Dr. Jessica Cardy-Shawn. Dr. Richard Cho.
Present.
Okay. Dr. Pritesh Gandhi.
Present.
Dr. James Hildreth.
Present.
Mr. Andrew Imperato.
Present.
Mr. Victor Joseph.
Present.
Ms. Jo Linda Johnson.
Present.
Dr. Jonae Caldoon.
Present.
Dr. Rachel Levine. Dr. Octavio Martinez.
Present.
Dr. Marcella Nunes-Smith.
Present.
Ms. Shannon Pazor.
Present.
Dr. Tim Putnam.
Present.
Mr. Vincent Torrenzo.
Present.
Ms. Mary Turner.
Present.
Dr. Homer Venters.
Present.
Mr. Bobby Watts.
Present.
Ms. Heyang Yoon. Okay. Madam Chair, we have a quorum for the meeting.
Many thanks, Captain Wu. Now it is my absolute pleasure to transition us to hearing from our guest experts. We are taking on, as mentioned, 2 very important priorities this month. We'll hear from one expert in each of those priority areas. First, regarding access, equitable access to PPE treatments and therapies and testing. And then we will have a Q&A and then hear from a guest expert speaking about long COVID. So it is my absolute honor to invite and welcome Dr. Bruce Siegel to share a comment with us. Let me briefly introduce Dr. Siegel, who is the president and CEO of America's Essential Hospitals. Since joining America's Essential Hospitals back in 2010, Dr. Siegel has used what is really extensive experience in healthcare management, in policy, public health, to advance the association's advocacy, leadership development, and population health work. America's Essential Hospitals has grown dramatically under his stewardship, becoming an even stronger voice for the hospitals that care for the most vulnerable. He served previously as director of the Center for Healthcare Quality at the George Washington University and as president and CEO of two member systems, the New York City Health and Hospitals Corporation, as well as Tampa General Healthcare. He has also served as New Jersey's Commissioner of Health. Dr. Siegel, thank you so much to the organization, certainly, and to all the members for just really tremendous work getting us through this pandemic. We know we're not quite on the other side yet. We're so eager to hear your thoughts. Thank you for joining us today. The floor is yours, Dr. Siegel.
Thank you so much. Really appreciate your invitation here. And thank you, Dr. Nunez-Smith, for your leadership and commitment, not only through this group, but longstanding around eliminating health and social disparities. We are delighted to be working with you and all of your colleagues. First, just a couple of things I'll just mention as a disclaimer. The opinions and findings and conclusions expressed during this event are strictly my own and don't represent the opinion, views, or policies of the Office of the Assistant Secretary for Health, Office of Minority Health, or Department of Health and Human Services. And I will not be mentioning trade names or commercial practices or the like, and I have no conflicts to disclose. So with that said, I very much appreciate the invitation to speak with you today. As your chair mentioned, our association represents those public and nonprofit health systems that serve the most vulnerable. And these systems have been truly on the front line of our nation's pandemic response. We applaud the swift action of the administration to establish the Health Equity Task Force, and we applaud its efforts to vaccinate all those who are eligible. We are making progress, but there is still so much work to be done, as you know, to address inequities in our COVID-19 response as well as across the healthcare system. I'll focus today on personal protective equipment, testing, and therapeutics, though the issues we face as a country and as a healthcare system really require a response that obviously goes far beyond that into other issues as well. So I will provide some context around these three areas if you'll allow me. So let me start, first of all, with some of that context, an issue that I know that you have grappled with here, and that is the issue of race, ethnicity, and language data, and other data around who our patients are and who could be our patients. The president's executive order on ensuring an equitable pandemic response and recovery stated that the lack of complete data disaggregated by race and ethnicity on COVID-19 infection, and I'm paraphrasing here, has further hampered efforts to ensure an equitable pandemic response. We have been steadfast in encouraging the collection of patient demographic data in a culturally linguistic and linguistically sensitive and linguistically appropriate manner. And we can't understand the challenges we face unless we have this information and use it. And I know in your prior sessions, you've gone through these issues and you've seen the huge proportions of data reports that we get which simply lack race, ethnicity, language, and other really important data for us to craft a response. If anything, the unconscionable rates of infection and death among Blacks, Latinos, and other people of color have emphasized how the urgency of this. We've spoken about it for years. I know I was involved with some early rollout of these modules in hospitals, probably about 15 years ago. It's time to stop talking about it and to do it across the healthcare system. Let me turn to testing. Patients served by essential hospitals who are already at higher probability for severe disease due to comorbidities also experience social risk factors that create barriers to accessing testing. Things like being unable to take off from your job or difficulty in traveling to distant testing sites. And let me offer two examples from our members of defining the problem as well as solutions. Data from Hennepin County Medical Center in Minneapolis, Minnesota was published in an article in JAMA in June 8th. And their researchers studied patients' demographic and clinical and social characteristics depending on where they initiated testing, through a telehealth encounter, an outpatient or emergency department, or an inpatient unit. And what they found, perhaps not surprisingly, that white and English-speaking individuals disproportionately initiated testing via telehealth visits at a distance, while Black, Native American, and patients who do not speak English as their first language disproportionately initiated testing through the emergency department. And notably, testing initiated via telehealth or outpatient encounters was associated with lower rates of subsequent inpatient and intensive care unit care than testing that was initiated further down the stream. But it doesn't have to be this way. MUSC in South Carolina sought solutions. They helped create a statewide COVID-19 testing network to really push for equitable access to testing with a focus on geographically at-risk communities. And they were able to essentially oversample communities of color. And while doing tens of thousands of COVID-19 tests, 50% of them, nearly 50%, came from Black patients, who represented only a quarter of the state's population. We can address these inequities if we are purposeful in them. I also want to note one other thing here. A steady supply chain here is key. Frontline health workers face limited supplies needed to administer COVID-19 tests like swabs, nasal transfer media, and reagents. And that is also an issue that can drive disparities. And I'll go into that a little more in a second. Some of these supply chain challenges were even more on display with PPE and other supplies. Many essential hospitals faced acute PPE shortages and frankly were outbid in the mad scramble to acquire items like N95 masks early in the pandemic. The HHS OIG reported on this in March, noting that some hospitals used to pay about $1 per N95 mask, and now it went to $8 or $9 during the pandemic. That's a challenge, but imagine what it means for a health system which entered the pandemic already in shaky financial shape. A health system or a hospital dependent on Medicaid for its financing, or a hospital like some of our members in Texas, where literally almost half the patients are self-pay patients. Soon after the peak of the pandemic, I spent some time talking to a head of a public hospital in California that served many immigrant and farm worker communities. And I was brought to the edge of tears. They literally had to beg and borrow for PPE from other richer health systems who provided them for a while and then pulled back, feeling they needed to care for their own people. They were left short by our health system and by our nation. I'll also note that frontline workers in our hospitals who reflect their communities of color experience increased exposures to the virus in workplaces with limited access to PPE. And to be clear, the shortage of PPE left so many non-healthcare essential workers really exposed to the virus as well. And we saw the impact. Let me turn to therapeutics. Barriers to equitable allocation of therapeutics include inadequate access to the information, inability to schedule, or just a lack of availability of therapeutics nearby their communities. And these disadvantages have to be identified. Fortunately, we have seen some state-specific ethical frameworks for allocation of COVID-19 therapeutics designed to mitigate health disparities. For instance, the state of Minnesota has a framework that calls for each region to have several locations designated for monoclonal antibody infusions, taking into account geographic factors, demographics, and population need. And I think these state-based frameworks can serve as examples, but still, federal response and guidance is still needed. We also need a willingness of healthcare systems and infusion facilities, frankly, to accept referrals from outside their systems, provide care for all, including those who lack a connection to their system and who lack a regular primary care provider. As I come to the end, I want to address a couple other things. One issue which is timely is infrastructure. One of the challenges of facing the COVID-19 surge was the often antiquated infrastructure that many of our essential hospitals have because of their financial state. Having limited swing space, limited space in general, limited the ability for some hospitals to set up infusion clinics for administering COVID-19 therapeutics. Realize the kind of space you need there to isolate these patients from the rest of the healthcare system. The lack of single beds or single bedded rooms in many of our hospitals impeded infection control and made it hard to do mitigation strategies like isolation. And to be clear, many of these hospitals lack universal beds, which can easily convert to ICU beds during a surge. So investment in the infrastructure of the safety net is essential. Finally, in terms of some recommendations, we need to make sure first that any relief to providers is targeted to need, targeted for who they care for, and targeted and takes into account the disadvantages they may come into being dependent on Medicaid, being in a financially shaky place to begin with, even before entering the pandemic. We need to fully fund hospital preparedness programs, which we have not as a country done for many years. We need to strengthen surveillance systems at local levels to make sure that we have the timely detection of cases that can translate into early interventions, as we've seen. And frankly, we need to strengthen America's safety net overall, to have the resiliency of our healthcare system as a whole to respond to pandemics and other public health emergencies. Thank you so much for your time and attention today.
Thank you so much, Dr. Siegel. Really very illuminating, very much appreciated. Again, all the work you're doing, all of your member healthcare systems and hospitals. We do have time for questions, should there be any from the task force members. The floor is open. Please, Dr. Martinez.
Thank you, Madam Chair. Dr. Siegel, thank you for that presentation, your remarks and recommendations. I want to start with what you started with, which was, the data and metrics, where we have fallen short for decades, as you pointed out, across the board. I'm Octavio Martinez, Health Equity Task Force member from Texas, where we also have struggled with ensuring collecting the right data and having the right metrics. But I'm going to come about it from a different perspective because of your unique experience and perspective. Is there a compelling rationale or argument of why we should not collect this key data to address health disparities and inequities?
I do not see any rationale why not. It is legal. Our data systems are now in a place where they can collect it and stratify outcomes according to these measures. As we've made the transformation to digital health and we have spent tens, maybe hundreds of billions of dollars in the nation, there's absolutely no reason why we shouldn't. And there are no laws at the federal or state level that preclude this. Although I know I've heard couple of state health officers say that to some of my members, and they were sadly mistaken, of course. And the benefit of it is it can make our response so much better fine-tuned and help us so much better understand what's happening in our communities and how the dynamics of the health system and its interaction with the pandemic is rolling out. There is no reason not to. And by the way, we've been working on it for years. We know how to do it.
Right.
Let's be clear about that as well.
Appreciate those remarks. Thank you, Dr. Siegel.
Thank you so much. Please, Ms. Turner.
Dr. Siegel, I work at North Memorial Medical Center, which is right down the road from Hennepin County, which you mentioned. And I would just like to express my appreciation for your portrayal of what it was like on the front lines, being a COVID ICU nurse there. And I appreciate fully your recommendations to fully fund preparedness for the hospitals. Because like I've often said through these many months, I never again want to have one N95 that I wear till it falls off my face. That's all I ask. So thank you for your work.
Thank you for your work, and well said.
Thank you. I have one question for you, Dr. Siegel. I wanted to perhaps have you talk more. You gave us really clear, pragmatic ideas in terms of recommendations and suggestions. I agree with everyone else too for laying out the full scope of the problem. And perhaps a conversation to reflect on and start now. But you talked about targeting provider relief to need, and perhaps you can speak a little bit more to that.
Sure. So there's been a long debate about this since the beginning of the pandemic. And early on, and I don't want to, rehash history, but some of the allocation formulas that were used by HHS in the difficult moments, back a year ago, did frankly tend to advantage hospitals who had more advantaged patients, more insured patients, because they were driven by a hospital's total revenue. And if you're dependent on Medicaid, your revenue will be proportionately less because Medicaid pays less than half of what private insurance pays in America. It's a legacy of structural racism. It is a manifestation of structural racism. So, many of us worked hard to correct those. And I will say that the last administration did work hard to correct some of that. But we still are in a place where many of these organizations are in dire financial straits. Even though they received funding, because of the magnitude of the crisis, they are still in crisis. And for many of them, they have seen changes in their local community. There's still fewer patients coming through their front doors. And as long as we have a fee-for-service medical system, and it is what it is today, that will mean less revenue and less ability to meet this moment and to meet this challenge. So I grow concerned sometimes. There's been a fair amount of media recently talking about how some hospitals got wealthy off provider relief funds. And I can't speak to that, but I can say a lot of hospitals didn't. And there are a lot of our public and state-owned hospitals in America who continue to struggle and who need this to happen. Distribution based on cases, distribution based on, their dependence on things like Medicaid is very important. And we've been making this case to HHS and the administration. And, in the weeks ahead, there's still $24 billion that needs to be distributed left in provider relief funds. And so we'll see what happens.
Thank you so much, Dr. Siegel. I really appreciate that. All right, thank you again for joining us. I don't believe I see other questions. This was incredibly helpful for us in our content. I'm sorry, Mr. Watts, did you have your hand raised?
No, I want to point out that Dr. Tim Putnam has his hand
Thank you
raised.
so much, Dr. Putnam. It's cut off on my screen. Please, you will get the last question for our guest.
Thank you so much, Madam Chair. First of all, Dr. Siegel, thank you very much for presenting to us. I certainly appreciate your work and the work that your organizations do. I do want to, this has been an issue that the Subcommittee on Healthcare Access and Quality has run into, specifically that many hospitals, many physicians serve patients that are paid at significantly lower rates than many commercial patients. So it leads this one covered patient is not the same as another. I know your organization's put forth several recommendations to rectify that. Can you just give me your top one or two to help us understand how we can address this? Because I think it's a problem on a regular basis, but it was exacerbated during the pandemic when resources became scarce.
Yeah, so I would say a couple of things about that, and thank you for the question. One thing we've seen over the years in the regulatory framework, and this predates this administration, has been really increasing lack of emphasis on ensuring that Medicaid rates are adequate to ensure access. That was something that was very much part of the regulatory framework 15 years ago or so, or before. And increasingly, for a number of reasons, that has just really fallen by the wayside over the years. And we urge HHS and CMS, as they think about the adequacy of rates, and do they promote and ensure equivalent access. And then in the longer term, we need to ask ourselves as a country, are we going to allow Medicaid rates to stay so low? Is that what we want? And I think at least getting them to the Medicare level would be a significant first step in our country. This will not be easy. States have a huge amount of sway, obviously. But the fact of the matter is, there is so much more federal money now than state money in Medicaid. People don't realize how much has gone to one side, that we think it's an urgent federal issue as well.
Thank you.
Thank you so much. Thank you again, Dr. Siegel. On behalf of the entire task force, thank you so much for the work you're doing, for joining us here today.
Thank you for your work.
Thank you.
Great to be here.
Wonderful. We'll transition to our second guest expert who's joining us today. It is my pleasure to now introduce to all of you Dr. Margot Gage Whitfleet. So Dr. Gage Whitfleet is a social epidemiology professor who has post-acute sequelae of SARS-CoV-2 infection, also, of course, called long COVID. She has a bachelor's in psychology, a master's in health psychology, and a doctorate in social epidemiology and public health. She's currently faculty at Lamar University. She was awarded special recognition by Congressman Joaquin Castro for the advancement of social justice. Notably, she's also bilingual and speaks Dutch at home with her husband and children. And during her convalescent period from COVID-19, she created and published a coloring book for Mighty Girls with her daughters. Dr. Gage Whitfleet, we know you have expertise in many, many things. We're so grateful that you are joining us here today to share your lessons learned from being sick with long COVID. It takes a lot to come into a public venue and share something so personal and intimate. So we deeply appreciate that. And with that, the floor is yours. Welcome. My apologies, Dr. Whitfleet. I believe you might be on mute.
There we go. Thank you. I said thank you for having me. And indeed, it was a big decision over a year ago to come forward publicly about my health situation. But I felt that I needed to do it because I kept seeing so many people, especially women and women of color, not being believed that our symptoms from COVID were lasting longer than what was being reported should have happened by the CDC. So in this presentation, I am going to briefly go over some of the lessons learned from being sick 15 months with COVID-19. So about a year and a half ago, back right before March, I was a healthy and professor and fit. I was a health researcher, very active in public life and with advocacy work. There was nothing wrong with me. I had no prior health conditions whatsoever. I exercised regularly and ate right. I was living a good life up until March of 2020. And then I took a plane ride that started my COVID-19 roller coaster. My whole family got sick at the same time, but they were sick for about a week, but I just kept getting sicker. I am the mom of two very active daughters named Angelina and Victoria. Angelina is 6, Victoria is 9, and we do all kinds of things together. So it's been really hard having been sick for so long, because the main question they always ask me is, when are they going to get the old mommy back? Because I'm no longer active. And even here today, I appear to you to be normal, but I'm having chest pain, pins and needle sensations running down my arms. I have ringing in my ears. I have a headache going. So a number of symptoms that I'm still having, even presenting to you here. And then by the end of the evening, I morph into a deconditioned 80-year-old woman every night. So it's very important that I pace myself. So I regulate my energy over day, and I have to think about what activity I do, because that's going to be it for the rest of the day. And it's very much similar to people who suffer from ME, chronic fatigue syndrome, and have been before COVID was even a pandemic. But I'm sure you guys have heard a lot about long COVID in general. So I wanted to bring it to you guys from a different perspective. I took up advocacy work for people with long COVID over a year and a half ago, and Health Magazine named me one of the unsung heroes of African American women, because I was speaking directly to the African American community and really trying to bring the message forward. But one of the most important things I wanted to speak about today is not just that situation. If you wanted to hear more about my journey, you can do that. My video diary is on YouTube. It's featured, my story is featured in The Conversation. It's had a number of views of how I went from one day being fit and then the next day waking up feeling as though someone, an unseen force, was suffocating me, or that I was walking in the Rocky Mountains only not being able to move. And that happened within the course of a month. And by the end of April, I had had my first seizure from COVID-19. And I had several other issues thereafter, problems with walking and needing to use a cane at night because it felt like I was walking on rocks. I also had a lot of neurological symptoms. Some of the only thing I could do, because light and sound hurt, was just color with my children. And so that's what I did. Or one of my oldest daughter, Victoria, would read to me. So they were really my lifesavers, and they didn't even know it because of bringing me that calm when I was experiencing a lot of my neurological symptoms. And so for us, what was a lifesaver for my family is because my kids had always been homeschooled, was virtual school. And that was great for us. And my children attend a great virtual school in Texas, RCI. They learn Spanish, they learn Chinese, they have fitness, and it's totally virtual. They have real teachers, it's a great community, and they get social activities as well. So for me being sick for so long, that was truly a lifesaver for my family. And so one of the things that I really want to recommend today is that we don't forget all family types, because right now in Texas and in a lot of other states, the virtual school is not going to be an option anymore, especially at the younger level. And what we need to remember is that all children will not be vaccinated by upcoming school year. And then you have long COVID patients like me, and I can't really risk sending my children out to school and then coming back and then potentially getting sick again, because that's going to set me back on bed rest for many, many days. And not only that, I almost died several times last year. So just coming back with, for example, the Delta variant is not something that I'm looking forward to. And you have a lot of people like me, a lot of family types like me. You also have the immune compromised people, people with chronic illnesses, and even elderly living with school-age children who might not be vaccinated, might not be able to get vaccinated, or might not want to get vaccinated, unfortunately. But I just would hope that this panel really recommends to consider all family types. So how do you go about doing that is the question. Well, the Elementary and Secondary School Emergency Relief Fund, ESSER, is one of them, one of the ways. At the moment, funding is there, but it's only allowed to educate children in the geographic boundary. So then that doesn't allow children like my children to stay virtually because of that geographic limitation that was put on the ESSER fund. So my recommendation would be to release funds to educate outside of geographic boundary and to allow the allotted money to be used for different purposes so that children like mine, Victoria and Angelina, have a school home next year, because we're still going to be in a pandemic this upcoming September, even though we are making wonderful progress with the vaccines and people getting vaccinated. So some people might be apprehensive about the effectiveness of virtual schools, especially amongst the younger generation. But I would like to remind you that this is really the next generation of students. Online learning is the norm in college. I was teaching online even before the pandemic, so why not for K through 12? My children are thriving. So if you happen to belong to those children who are able to thrive, who do have internet at home and this social support, this is a great option for them. I am also thankful that my children don't have to deal with school bullying and no risk of active shooters. So it's really time for education on that K through 12 level to evolve with this era because children are ready. And I know it asks, as an educator myself, I know it's asking a lot from our educators, but I think a lot of educators on that K through 12 level are ready too, especially considering the public health aspect of it. And unfortunately, in my state of Texas, there was a bill that would have allowed virtual schooling to exist this fall, and it was passed and approved. However, the governor wasn't able to sign it because of the inner workings of what's going on politically in my home state. And although I do understand that need to work on the political level to try to get things done, right now, public health should be our number one focus collectively as a nation. And so we got to put our political ideas and ideology aside in the name of public health. And one of those things is by protecting our children, by getting these virtual schools nationwide off the ground and making it a priority to get that done. So that's that with virtual schooling. The next thing that I wanted to share with you is just the unbelievable amount of bills that I'm having to comb through and as a long COVID patient. And this is something that people with chronic diseases have had to deal with even before COVID. And it's really unfortunate that still in America in 2021 that we're still dealing with this and still having this conversation. So as a public health researcher, I think we need more needs to be done to fix the healthcare system. It has been a nightmare for me navigating the healthcare system, and I'm well insured. So just imagine the people who maybe are lower educated or not as well insured, what they're having to deal with just to try to stay alive. And that's awful in one of the richest countries in the world. So that's one thing. Second thing is that in our society, integrative medicine needs to be the norm. I am having to speak with this doctor, this doctor, and then combine it all together. And that's something that should just be done from the start to enable to get a wider perspective of how we can heal the patient. I think our country would come a long way if we were able to start thinking in that direction. So thank you. That's what I wanted to share with you guys today.
Thank you so much, Dr. Whitfleet. Really appreciate you coming with us today. And and feel free to stop share too. We can return to our full conversation. Thank you. We talk so much about data as a group, which is pivotal. We just spoke of that with Dr. Siegel as well. We need the data, no question, but we also need the narrative. And you just remind us of that, just how important it is to understand the individual lived experience as we talk about COVID-19, and never more true than with long COVID. So just very much grateful that you are highlighting where needs exist through coming and sharing your own personal testimony. We do have a few minutes for questions from the task force members, so the floor is open. Mr. Imperato, please.
Thank you, Madam Chair, and thank you, Dr. Gage Whitfleet, for your compelling sharing of your story today. My question, you mentioned kind of the challenges with the healthcare system, and I just wanted to see if you want to comment on what your experience has been in navigating short-term or long-term disability benefits and navigating getting accommodations that you might need in order to be able to keep working, and if you have any recommendations for us in those areas.
Yeah, absolutely. So navigating this has been an absolute nightmare because you're sick. And so having to read through the paperwork and make the telephone calls, it's been horrific. And getting all of the bills in the mail and having to keep up with that is just, it's asking a lot from sick people. And for me, I have not had to go through the disability system because I really didn't want to do that. So I haven't. But I do know a lot of women who have, because I started my own support group, and they are having a terrible time at it. They're getting denied. People aren't being believed. Nobody can tell us, of course, how long we are going to be like this. And a lot of people don't have the compassion to understand that, we are disabled, and we don't know how long we're going to be like this. And not everyone, has the luxury, as I do, to be able to work at their own pace. So for me, with my employer, I had to fill out the paperwork and go to the doctor and get a type of doctor's note. And so that worked in my situation. But there's so many people where it's not working, and they're getting denied, and they don't know what to do, and they're losing their jobs because they can't keep up with their work. Their work is more physical, but it's also taxing. COVID is taxing not only physically, but also mentally. So it's a challenge. How we run things in this country for sick people is outrageous, and it needs to be changed.
Thank you. Dr. Martinez, please.
Thank you, Madam Chair. Thank you, Dr. Whitlet. Excellent presentation. I commend you for willing to speak from a personal perspective as well. I'm a psychiatrist by training here in Texas, so a fellow Texan. So it's good to see you in that respect as well. I'm glad you mentioned integrative care. So really having a more holistic approach and really addressing physical and mental health and substance use issues should be happening in a much more synergistic, concerted fashion. I was wondering if you'd be willing to give us additional perspective on the mental health implications of what you are dealing with, or as an advocate who others are dealing with, especially as it relates to long COVID, and knowing that in fact the pandemic is affecting all of us, but it's affecting those with long COVID in a very, very unique way that we really need to understand, and the ongoing, I think, support that the healthcare system really needs to provide. So I'd really like to hear if you're willing to share more of a perspective also from the mental health implications.
Yes, absolutely. So for me, I have a mental health professional on my health team. That's one of the things that I knew early on I needed to have. So I had my neurologist, my cardiologist, but also my mental health therapists on that team. Because when you're sick for so long, it's not surprising that you're going to get depressed. And then also with how I had issues with doctors just not believing me, because I was one of the first people in Texas to get COVID-19 when we were starting to know about it back in March, even though, of course, there's people that this happened to earlier, but our CDC list was super, super short, and I never had a fever. So doctors were like, well, you don't have a fever, so it's not COVID. They tested me for everything else, and it was never anything else that they were testing. So that brought about, a lot of, just because doctors were scrambling to evolve with COVID, and I was one of the first ones on the front line. That brings just so much anxiety and just problems just by going to a medical professional not being believed, or coming in because I'm having respiratory distress, and before they treat me with compassion, they're drug testing me and asking me, what have I taken? And I'm like, I'm a professor. I live a clean life. I've taken nothing. And until my drug tests come back clean, then they want to start talking to me like I'm a person. So I early on circled myself with different professionals, and one of them being a mental health professional. I think we've all heard the news reports of people with long COVID who are killing themselves because the pain has just become too much to deal with day in and day out. So I think we definitely need to sound the alarm with the fact that you need to get mental health care, however it is that works for you, because everybody is going to be different in that respect, but it definitely needs to be part of your practice of care.
Thank you so much. Dr. Venters, please.
Thank you, Madam Chair. Thank you, Dr. Gage-Whitlet, for sharing your story. I wanted to call on your expertise as a social epidemiologist and, kind of put it together with your story. Most of the work I do is in jails and prisons. And so I go places where most of the people who had COVID, or many of them, were never tested. And many of the people who have long COVID in these places, hundreds of thousands probably around the country, given that we have 2 million people incarcerated. Many of those people were never told or got an approved a diagnosis of having COVID. Now, we have about 10 million people a year go home from these places, jails, prisons, ICE detention. And so as they go home, I wanted to ask, for the people who were never diagnosed and the people who don't have any legitimate path right now to have a medical professional say, I believe you, that you had COVID and you have long COVID. What do you think that does for the long-term engagement of communities of color where there's overrepresentation of incarceration for the rest of our health system? That is, for all the diabetic care, hypertension care, all the health systems that we think are, safety net health systems. What happens to engagement with those for these people who disproportionately have never been told or given any kind of like a seal of approval for having COVID, let alone long COVID?
Right. That's going to involve education. So we're going to have to go into these communities. That's on the government to go into these communities to educate these people about what's going on. That's a public health treatment or a public health intervention that's going to need to be a priority of ours because it's not, and especially with the prison population, because that was just a community setting. It's spread in there like wildfire. They had no access to hand sanitizers, yet in some prisons they were making hand sanitizers for the non-imprisoned population. So for us, they were making it but couldn't use it themselves. So what we do and how we ignore the health of the prison population is atrocious. So even I, as someone, as a professor, had a problem with the healthcare system. So can you imagine someone who has the mark of being, who has been a prisoner? So an inmate, it's even worse. So that's on us. One of the things I can say positively is recently the CDC released a report letting doctors know that they're going to need to expand their vision, because many of us early on didn't have a COVID diagnosis because the COVID tests weren't up to par as they are today. So that's just a form of education. We're going to have to focus on, targeting these communities, because it's not only just the prison populations, but a lot of our children are long haulers as well. And we might not even realize it or know it. The Dutch from the Netherlands just released a study about the number of long haul children that, that they're finding in their communities. So there's a lot of people in that boat. Unfortunately, the prison population is going to be a big one of them, and we're probably going to do them a disservice as we have historically done.
Thank you, Doctor. Ms. Turner, please, you get our final question to our guests.
Yes, thank you, Dr. Gage. I have a question. You seem to be a strong advocate of in-person education. As you know, in our schools, in our in-person schools, often if they're fortunate to have nursing staff, many children, this is their primary access to any health care. So what would be your recommendations if we move strongly into in-person schooling for those children that their education system is their primary source of medical care? We don't want to leave that aspect out of it, is what I'm saying.
Right. I'm an advocate for virtual learning. So for learning online for young people. And right. So for those students who are learning online and they are using the school nurse as their primary form of healthcare, we're going to have to think what solutions can we do in order to bring that to them. You can have you have your certain number of students, they can do home visits. That if that's the case, if those students need that. You can have community centers where they go to that are already established. And because you're dealing with real people at these virtual schools and not just, talking to an automated video, it's on the school to check, do their checks and balances to make sure that's happening during their small group sessions. So it's about you can bring everything from a brick and mortar school online. It just takes a little bit of change to get there. It's possible because you can still visit these children at home and do a safety check.
Thank you.
Thank you. So Dr. Gage, we just want to Thank you again for all of your advocacy for joining us today, especially knowing that at this moment you are navigating and dealing still with the symptomology. So we certainly wish you continued healing, and the tremendous insights will inform our work. So on behalf of the task force, thank you again for joining us.
Yes, thank you for having me. I can't tell you how refreshing it is that this task force exists, because it's been a long journey in order for us to have our voices heard. So I really appreciate you guys doing this. Thank you.
Thank you. Thank you. Lots for us to consider. We will, at this point, take a break. It is, by my account, 3:01 Eastern Standard Time. We will resume at 3:10.
Childress. Okay, we'll come back to her. Dr. Sarah Bleich.
Present.
Dr. Jessica Cardy-Shawn.
Present.
Dr. Richard Cho.
Present.
Okay. Dr. Pritesh Gandhi. Okay. Dr. James Childress.
Present.
Mr. Andrew Imperato.
Present.
Mr. Victor Joseph.
Present.
Ms. Jo Linda Johnson.
Present.
Dr. Jonay Caldoun. Okay. Dr. Rachel Levine. Dr. Octavio Martinez.
Present.
Okay. Dr. Marcela Nunes Smith.
Present.
Ms. Shannon Pazur.
Present.
Dr. Tim Putnam.
Present.
Mr. Vincent Torrenzo.
Present.
Ms. Mary Turner.
Present.
Dr. Homer Venters.
Present.
Mr. Bobby Watts.
Present.
Ms. Heyang Yoon.
Present.
Okay. Ms. Mara Alvarez.
Present.
Okay. Thank you. With a quorum, back to you, Madam Chair.
Thank you so much, Captain Wu. All right, it's really wonderful. Those who've been following us will see that we had an additional name added to the roll call. Wonderful to welcome you, Ms. Shannon Pazur, to the COVID-19 Health Equity Task Force. We're really, really thrilled to have you join us. We have a couple of minutes now for you to just introduce yourself to the group and to those who have joined us for the meeting. Thank you. The floor is yours.
Thank you so much, and thanks for that introduction. Good afternoon, everyone. My name is Shannon Pazur. I am a senior counsel with the Office of Legal Policy at the Department of Justice. I've been with the department for a little over 10 years. Our office serves as the principal policy advisor to the Attorney General and the Deputy Attorney General. And in that role, we cover the entire landscape of policy issues that the department faces. As a result, I have experience in a wide range of subject matter areas, including civil rights and equity issues. I've only been with the task force officially for a couple of days now, but I have been following your work for the last several weeks and am incredibly impressed with what you've accomplished in such a short period of time. And I'm very much looking forward to working with you. I appreciate the warm welcome I have received already and can't wait to get started. So thank you for allowing me to join this important effort.
Thank you. We're so grateful to have you and your expertise with us, Ms. Pazur. Thank you. So at this point now, we are going to transition to discussing this month's interim recommendations. Up top, of course, again, thank you to each of the task force subcommittee chairs, as well as to all the members. If people only knew kind of all of the many hours folks are spending in subcommittee meetings, working so hard and thoughtfully in these recommendations. And of course, to the federal staff team, Dr. Okafor, our executive director, thank you for your leadership leading the federal staff team through all of this support, getting us through these sprints at a tremendous pace and without sacrificing anything in terms of the quality and thoughtfulness of the recommendations. I will hand the floor over to you now, Dr. Okafor.
Thank you, Madam Chair, and thank you so much, every member of this task force. You always do extraordinary work, extremely committed, and of course, it is a pleasure to really introduce the work you have done this month. So this month, as many of our viewers must have heard, and for those joining us, the members of the task force worked diligently to discuss and deliberate on long COVID, PPE testing, and therapeutics. And I'll move forward now to remind those that joined us for the first time about the mission of the task force. This task force is under the Executive Order 13999, which is the presidential executive order that really requires the group to discuss how they could make recommendations for the nations to mitigate health inequities that are caused or exacerbated by the COVID-19 pandemic, and as well identify ways that we could prevent such inequities in the future. So as Madam Chair mentioned, we have 4 subcommittees that have done this work, and I will move forward. We will make this presentation available so people can read more of the mission of the task force for those joining newly to watch and view this important 5th task force public facing meeting. So we have basically a lot of people that were involved. They are subject matter experts that helped to shape the work that the task force members did. Also, the task force received a robust literature reviewed on issues surrounding this topic, which our interns have worked on, and they also brought in their own expertise to the table. So I want to acknowledge the subject matter experts. And then with that, I'll move forward to highlight the themes of the interim recommendations that came up across the 4 subcommittees. As I indicated, those 4 subcommittees, we have the data, analytics, and research subcommittees, and we also have the health care access and quality subcommittee. The 3rd subcommittee is our collaborations and communication subcommittee, and the last one is our structural drivers in xenophobia. Across these 4 subcommittees, there were key things that actually we wanted to lift up as themes that cut across in 4 bucketed areas. The first one is themes on data, shortfalls, and how we can address that going forward. I will use an example with the requirement or the recommendation, basically, that we should consider creating a national coordination of research standards and standardized methods for disseminating research relating to long COVID, as well as set a national research agenda that centers on health equity and COVID-19 for the minoritized, marginalized, and underrepresented population, like those who are medically underserved. Under the same bucket is a key recommendation about data transparency that are needed, as well as completeness of data and information on access to therapeutics and how this could differ across communities. I'll move then to the second bucket categorical theme, and that is the theme of increasing awareness and access to services for people that are living with long COVID, as well as access to the therapeutics and the PPE and testing. I'll use 2 examples to highlight that. One is really to launch interagency-led campaign on long COVID patient rights, as well as also information on the supplies of these services and critical support services that they need. The second one I would like to really highlight is the fact that we need the suggestion to ban coverage limits for long COVID, as well as consider providing comprehensive and appropriate treatments for people who have insurance and people that do not have insurance, so that there is that protection when you look at it from public health perspective. Going to the 3rd bucket, I would like to identify the bucket around protection of workers and the workplace as a setting. In this bucket, I will highlight the recommendation to pass public policies that create jobs and rebuild the country's infrastructure. Examples were used with American Job Plan, and of course, we are aware of the American Families Plan that also invests in children and families, as well as the minoritized, marginalized, and medically underserved community with long COVID. This is also highlighted by our speaker, who mentioned about the children that are also experiencing long COVID and their families. I will move to the last bucket, which is to engage community. And in this bucket, I'd like to quickly highlight the recommendation for us to create a public-private partnership that will include not only the clinicians or the medical providers, but will also include the patients and the communities that are affected by long COVID disproportionately and also at large. And the last one will be really in the area of recruitment and funding of healthcare workers, especially those that represent the people who are disproportionately affected by long COVID. With this, I will move to introducing our subcommittees, because they are the ones that did the work, and they will be in a position to share remarkable work they have done. And it is my pleasure to introduce Dr. Janae Cardoon, who is the chair for Data Analytics and Research Subcommittee, to kick it off. Thank you.
Thank you so much, Dr. Okafor. And of course, I want to thank my subcommittee members again for their work, Dr. James Hildreth, Andy Imperato, Victor Joseph, and Dr. Homer Venters for their wonderful contributions, and as well as the entire task force, the HHS team and staff, and just many team members. Everyone really put in a lot of work for the past several weeks, including for this June sprint. So next slide, our team had 2 interim problem statements for this month's topic that are listed here on this slide. The first one reflects really the lack of a robust investment in studying long COVID and a lack of research and data to both understand and respond to long COVID. And this is particularly concerning given what we all know as far as the disparate impact that COVID-19 has had on minoritized and marginalized communities. The second problem statement speaks specifically to therapeutics, and this would include treatments such as remdesivir, but also monoclonal antibodies, and the disparate access to and utilization of therapeutics. So on the next slide, for problem statement 1, we had 2 key recommendations. This is the first one. One is that we should really have a national research agenda on COVID-19 that is truly centered on and in health equity. Importantly, it should be shaped by minoritized, marginalized, and medically underserved communities. These communities should also be reflected in the diversity of research study participants. And importantly, these participants should also include the pediatric population. This agenda should include looking at the scope of long COVID that was undiagnosed, as we've talked about in this meeting, or untreated in the carceral setting or in other congregate settings, and also how racism and discrimination, especially within the healthcare system, impacts long COVID symptomatology, severity, treatment and referral patterns, and patient experience. And the government should also promote private-public partnerships to advance this research, and it should involve a variety of research methods. Our second recommendation is that there should be a coordinated promulgation of research standards, as well as a standardized method to disseminate this research about therapeutics and diagnostic practices, particularly so that clinicians can make well-informed and evidence-based decisions about treatment and management and referral plans for patients who do experience these symptoms post-COVID infection. So for our second problem statement on access and utilization of therapeutics, we had 3 recommendations. The first one is about the need for more data transparency regarding therapeutic access, utilization, and rates of hospitalization, particularly after monoclonal antibody use, which is intended to decrease the rates of hospitalization for those who are at high risk and have COVID-19. This should also include disaggregated data, which is, again, an ongoing theme, disaggregated data on access and utilization around minoritized, marginalized, and medically underserved communities. Our second recommendation is that the federal government should sponsor a study on monoclonal antibody utilization, particularly evaluating infection rates among minoritized and marginalized communities, and looking at how that compares to utilization of monoclonal antibody therapy and how that may impact incidence and severity of long COVID symptoms. And then our last and third interim recommendation is for a survey to be conducted of the general population about patient experiences, knowledge, and access to therapeutics. And this should include questions around access across a variety of settings. This includes long-term care facilities, home-based infusions, and in ambulatory outpatient facilities. So again, I would like to thank my subcommittee members for their contributions to these interim recommendations. And with that, I will open it up to see if any of my subcommittee members have any additional statements to add. Okay, hearing none, I will, or seeing none.
I believe Dr. Venters may have his hand raised.
Oh.
Dr. Venters.
Thank you, Dr.
Okay.
Sutherland,
Yes.
and thank you to the other subcommittee members. I just wanted to underscore how many minoritized and underrepresented populations really have not been counted in terms of just figuring out what is the baseline prevalence of this problem of long COVID. For instance, the federal prison system lists 45,000 people as being recovered from COVID. New York State lists 6,500 people as being recovered from COVID. Many of those places, my experience is, are not recovered. They're actually struggling day to day with really debilitating symptoms and even new disability from long COVID. But because they aren't counted, it means that resources and programs for them, not just behind bars, but when they go home, are going to be lacking. And so this approach that the subcommittee chair and the subcommittee is proposing is really essential if you want to get serious about being equitable in identifying and treating long COVID. Thank you.
Thank you so much, Dr. Venters. I apologize for not seeing your hand there. Any other subcommittee members? Okay. Turn it back over to you, Madam Chair.
We're having challenges with our, I think you have one more subcommittee member, Mr. Imperato.
I apologize, go ahead.
No problem, thank you. I just wanted to add, this is Andy Imperato, I just wanted to add, there were a lot of folks with disabilities who didn't feel comfortable getting medical treatment during the pandemic because they were immunocompromised and they didn't want to take the risk associated with going to a doctor's office. So as we think about kind of researching long COVID, I just think it's useful to recognize that some people didn't get diagnosed because they didn't feel it was safe to go and get treatment. And then that can be used against them on the issue of whether what they have is actually connected to COVID. So I just bring that up as an equity issue.
Thank you. Anyone else that I may not be able to see?
Absolutely, we can tag team on that, Dr. Carlton. I do not see any other hands raised from your subcommittee members. Let me take this opportunity to thank you for your leadership, of course, on this, and to all of the subcommittee members for this set of important recommendations and for all the topics just raised. We do have moments if anybody else on the task force would like to comment on the Data Analytics and Research Subcommittee interim recommendations at this time.
Hi, this is.
Yes, please.
I just want to commend the subcommittee for the work to really ensure that we're collecting data from people living with long COVID themselves, as we have heard not only from Dr. Whitfleet, but we had the opportunity to hear from multiple representatives of groups that are actively working to build a community of people living with long COVID and to educate and build awareness around these issues. Collecting data directly from them is so important to ensure that our response as a federal government is accurately responding to their needs. It's obviously a difficult and challenging effort to do that sort of individual focused survey opportunities, but one that is definitely necessary for something like this, and something that we know is important to what we see in the disability rights movement and other spaces, hearing directly from people impacted. So I just want to commend the subcommittee for that.
Great, thank you so much, Ms. Alvarez. Wonderful, thank you. Dr. Okafor, back to you.
Thank you, Madam Chair. And with this, it is, and I want to thank, of course, the remarkable job that our data analytics and research did. And with that, I would like to introduce our Healthcare Access and Quality Subcommittee. You will hear the remarkable work they did, and it is with that that I ask Dr. Tim Putnam to take it away and share with the viewers what you've done. Thank you.
Thank you, Dr. Okafor. I really am honored to work with some talented members and committed people in the subcommittee. Myra Alvarez, Dr. James Hildreth, Vincent Toronzo, Mary Turner, Dr. Homer Venters, Bobby Watts, and Dr. Pritesh Gandhi. Really put in a lot of work, a lot of effort. Unlike the previous subcommittee, we have 7 problem statements and multiple recommendations, so hang with us. We did hear a lot from committed healthcare professionals that are working diligently on this condition, new disease that's out there, as well as many patients that are suffering it from it, like previous speakers. The one thing I know I echo the subcommittee members, that the patients that are suffering from this, I want you to realize we know this condition is real. It's debilitating, and it needs to be taken seriously. So that was a theme of much of the work. And if we go ahead, I'll summarize the problem statements that we've come up with. Again, there are 7, so hang with me on this. Generally, minority populations lack access to care, and long COVID has compounded this for a couple of reasons. One, it's a new disease, a new process. We're learning more about it every day. And many of the patients we're talking about that lack access to care feel like they're at the end of the line. It's not easily diagnosed or treated, and inconsistent care or inaccurate care complicates this problem. Problem statement number 2, we've heard several cases of patients that have been denied coverage for necessary treatment for long COVID, even when presenting with classic symptoms. So that needs to be standardized, and we need to be able to make sure everyone has access to care and coverage. Problem statement number 3 is blatant or latent racism exacerbates the lack of trust throughout the healthcare system. This is particularly problematic with long COVID, as a diagnosis is based on symptoms that are conveyed by the patient and not some sort of quantitative lab result or x-ray. It's important to strengthen that patient and provider relationship, and we'll benefit from that. So the next page to problem statement number 4. Throughout the pandemic, the PPE supplies should have gone to protect the people that were at most risk of harm, to stop and potentially stop the spread of disease. Instead, we saw a lot of the supplies going to those who could pay the most for it. PPE supply, production, and distribution was chaotic and needs to be rectified. Number 5, like PPE, testing was in short supply and continues to be limited for many patients. As the virus mutates, and testing limitations will continue to hit the medically underserved the hardest. And this issue needed to be addressed early on and still needs to be addressed to a certain extent. Problem statement number 6. And specific to long COVID, many patients are advised the best treatment is rest and recovery. Unfortunately, this simple treatment is not available to many people experiencing homelessness. The lack of the ability to rest will exacerbate their conditions, causing them to experience a worsening of the symptoms and an increased use of expensive resources like emergency rooms and hospitals. And finally, number 7, geography and distance really prevents many people from receiving healthcare that they need. Telehealth can be a valuable tool for them, but is frequently inaccessible due to the lack of broadband access or restrictive healthcare coverage practices. And it makes it infeasible for the physicians to offer telehealth services to their patients that need that. So those are our problem statements, and I'll go into the recommendations. Problem statement number one, again, very, very lengthy recommendations on this, but clarify and unification of disease classification is important for any disease, especially a new one like long COVID. A concerted effort needs to be made to standardize this long COVID classification. Number two is that revolving around community health workers. They've been increasingly valuable resource and have gained trust in marginalized communities and improve their access to healthcare system. Efforts should be made to expand and fund community health workers. Number three, like any new disease, our understanding and diagnosis of treatment is changing rapidly. Providers should have access to the latest knowledge for COVID and long COVID. We recommend a focus specifically on dissemination of this information to all providers. Number four, centers have been developed specifically to treat long COVID. But due to the lack of health coverage and travel limitations, many patients will not have access to these centers of excellence. Efforts should be made to disseminate the learning that exists in the centers to the safety net providers so that we can expand access to marginalized populations. Number five is safety net clinics lack the funding to provide monitoring and rehabilitation clinics that are rehabilitation equipment for their patients. We recommend that funding be made available when evidence-based research determines that such equipment would be beneficial for the patients. The next two recommendations, there's a general theme that many people have suffered from limited access to healthcare providers. There needs to be an effort, significant funding to expand the number of providers who are committed to work in medically underserved areas. A special focus should be toward people raised in these communities or others who are committed to long-term solutions in the area. Building trust in communities over the long term is really a solution as opposed to just some services coming in and out for these populations. Moving to problem statement number two, long COVID has many disabling and debilitating conditions that need to be uniformly recognized and covered. Recommendation number two is our understanding of long COVID's impact on children is growing daily. Many children didn't have an acute COVID diagnosis, but this should not limit their access to care when experiencing long COVID conditions. And recommendations number 3 and 4, long COVID has a complex diagnosis and treatment process. It's important to take a patient-centered approach that allows for the appropriate care and coverage. Moving on to problem statement number 3. Diagnosis of long COVID is based on symptoms conveyed by the patient and not a specific test. Providers who gain trust with their patients are more likely to do a thorough job eliciting those symptoms, which will improve the diagnosis and treatment. We feel strongly the development and requirement of training to assess unconscious bias will be beneficial to providers and patients. Recommendation number 2, of a long COVID diagnosis, there you go. If a long COVID diagnosis is dependent on a positive COVID test, many people who were denied the initial COVID testing will again be denied access to care for long COVID. This is an issue that needs to be removed. Long COVID diagnosis needs to be removed completely from a positive COVID diagnosis, especially in situations where testing wasn't available. Problem statement number 4. First 2 recommendations tied to PPE. It's imperative that our healthcare workers, providers, and essential workers feel safe. Sadly, early on in the pandemic, to provide care for our patients or perform essential tasks, many put their own safety at risk. We must have a better plan to stockpile, produce, and equitably distribute protective equipment in the face of a national emergency. This just is something we need to be better prepared for today and in days moving forward. Number 3, many facilities that have vulnerable populations have low vaccination rates, putting staff, patients, residents, and inmates at increased risk. Funds should be used to prioritize and encourage vaccinations at these facilities. Problem statement number 5. COVID testing access and coverage remains inaccessible for many. We encourage that testing be accessible and at no charge to help quickly identify when regional outbreaks occur. And this is completely possible given the fact the mutation of the virus and areas that have low vaccination rates. Problem number 6. Commonly, the best treatment for many long COVID conditions is rest. Many homeless shelters offer night-only services. We're requesting that both clear and consistent federal guidance and prioritization to fund solutions to allow people experiencing homelessness and long COVID have the ability to rest during the day. And finally, problem statement number 7. Inpatient care is always preferred, but we must realize that telehealth has been a valuable solution for many patients. However, many patients don't have access to telehealth services, and we need to create reimbursement solutions where providers can afford to be able to offer this service. In addition to expansion of broadband services, we need to be able to have funding for equipment and training for providers to effectively deliver telehealth. Now, those are the recommendations from the Subcommittee of Health Access and Quality. I am going to open it up and turn it over to Vincent Toronzo to start the discussion with all the members of the subcommittee. Vincent?
Well, thank you, Dr. Putnam. I really appreciate it. And I just want to thank the rest of the subcommittee for all the work that they put in to these recommendations. Well, I just want to start off by saying that, as we heard from Dr. Siegel earlier this meeting, PPE for healthcare providers were incredibly scarce during the early months of the pandemic, and we've known that for a while now. And really, for some hospitals, it is still scarce up until a couple months ago. But that's why it's so important to make sure that the federal government maintains an adequate stockpile of PPE, because we don't want to face that issue ever again in the case of future pandemics, as well as creating a rapid emergency production plan to distribute PPE to several hospitals and healthcare clinics. And additionally, with what Dr. Whitfleet mentioned earlier on how many people have been suffering with prolonged symptoms of COVID-19, that they've really faced a bunch of obstacles when trying to receive care. And we know this to be true because many people suffering with long COVID were never hospitalized or they never got tested. And this, in many clinics created to provide care for patients with long COVID, almost serves as a ticket to receive that adequate care. So that's why it's really important with the recommendations that we've made, that we ensure that patients receive access to treatment for long COVID, irrespective of whether they received a positive test for acute COVID or for which they were or were not hospitalized. And one last point I'd like to personally voice my support for is the fact that we make sure that pediatric patients receive care for long COVID, because as we know, there have been reports of incredibly healthy and strong student athletes who were at the top of their game and once receiving COVID, contracting COVID, and then now suffering from long COVID symptoms, they are really not at the top of their game and really have been almost weakened by COVID. And we have to make sure that our student athletes and every young person in this country can remain healthy and strong and get them the adequate care that they need in case that they are suffering from long COVID. Thank you, Dr. Putnam and Madam Chair.
Thank you, sir. Appreciate your input and all the work you put in this month. Let me open the floor to Mary Turner. Mary?
Okay. This pandemic has, if it's done nothing else, it has demonstrated the need for the care and compassion that one receives in inpatient care. We have telehealth we see as a supplement and most likely a very valuable supplement. But I have over a decade, I have traveled upper Midwest and watched town after town lose their clinics and their hospitals. And I would hope to see next month when we start to discuss the future, that funding to help open up clinics and hospitals again, and to make sure our hospitals that are in rural America and also in our underserved inner city hospitals that are now being closed, that they remain open because nothing can compare to inpatient care. And I say this from my meager 45 years of experience taking care of patients, that it is vital that people have the access both in telehealth and in inpatient care. Thank you.
Thank you, ma'am. Appreciate your commitment to making sure that everyone has access to care. May open it up to Bobby Watts.
Thank you, Dr. Putnam. I want to point out, I think 2 recommendations and problems statement 6 were overlooked, at least they weren't read. So I just want to point out the importance of at least one of them, the importance of medical respite. I really appreciated hearing directly from Dr. Gage Whitley. And it was just heartbreaking what she's gone through. And I was thinking of people who, as she said, did not have the advantages that she had, including people who don't have a home. And we know that housing status is one of the strongest social determinants of health. And based on the history and current practices, people of color are greatly overrepresented among those who are experiencing homelessness. So this is a matter of health equity, social equity. And it is really important that some of the most basic human rights, a place to rest, a chance to get better, be afforded to those who are most vulnerable in our country during this global pandemic. So I strongly encourage us to consider this, and I really appreciate our committee for all the hard work that we've done throughout this week and the many subject matter experts and Dr. Putnam's leadership of a sometimes unruly and raucous committee. Thank you.
Only rarely unruly and raucous, but always passionate and caring. And sir, I apologize for skipping over those. You're right, medical respite was a discussion that we had quite a bit, and are very proud to make sure that that recommendation is in there. Dr. Hildreth.
Dr. Putnam, thank you for your leadership, sir, and putting up with us. I think that recommendation number 1 and the problem statement number 3 bears emphasis. We had an extraordinarily accomplished Black woman who's an assistant professor at one of our universities who went to the emergency room with long COVID symptoms, and the first thing that she was asked to do was to be cleared of drugs, that she's taken drugs. I need people to understand how common this is, that if you're a person of color and you go to get medical treatment, oftentimes there are algorithms used that put you at a disadvantage from getting the most advanced treatments. It's in urology, cardiology, nephrology, obstetrics, whatever the specialty is, there are algorithms that are used that add points or takes away points from you based on your skin color. And it's time for us to stop conflating race with genetics. This is a problem that has to be ended. And if we don't do something about it, millions of people with long COVID, because of the color of their skin, will not get the best treatment available. And we got to make sure that this bias is dealt with. So I want to make sure that recommendation number 1 and the problem statement 3 bears emphasis. And I just want to make that point. Thank you, sir.
Thank you. Appreciate you bringing that up and all the wisdom that you bring to this subcommittee. Madam Chair, you can tell people care about this issue. We want to see things rectified and want to see, and we've heard from so many patients that really need to be able to have access to care and need fair and just care. So I will turn it back over to you for comments from the rest of the task force.
Thank you so much, Dr. Putnam. Again, absolutely right. Just pivotal, critical issues. My appreciation again, of course, to you for your leadership. Love all the adjectives offered up for the subcommittee. We know everyone is incredibly invested and committed, and that it is all in service of our country and what we need moving forward. So thank you all for your very, very hard work and those great recommendations. As Chair Putnam says, the floor is open for discussion regarding the healthcare access and equality interim slate of recommendations. Mr. Joseph, please, the floor is yours.
Thank you. I really appreciate all the work that's been done, and you can tell there's been a lot of emphasis put into the work and the recommendations. I also just really appreciate the emphasis put on telemedicine and the need for having affordable access to care. Not all the people we serve have affordable access to healthcare with long distance travel, places to stay, and meals. And so we need to have those being considered as well. It's not only important to devise the right tools in our providers' hands, but it's also important to make sure that the people we serve have affordable access to those devices too that are needed for telemedicine. So there just needs to be a little bit more done in that area and maybe look at some of the laws that prohibit that. And so with that, once again, to this committee, great job and thank you very much.
Thank you so much, Mr. Joseph. Dr. Martinez, please.
Thank you, Madam Chair. And yeah, I commend the Health Access Quality Subcommittee. Wonderful work. One thing I'd like to just comment on when it comes to health access and quality, and I think we've mentioned it indirectly, but I'd just like to state that it is also a workforce issue. We need to have and ensure that we are recruiting a diverse and equitable and inclusive workforce across the board, not just for physicians, but also our nurses, our social workers, psychologists, and the list goes on. That is so important to ensure not only are we bringing them on board, but also that we're instilling in them the skill sets that are necessary for the 21st century to be able to implement all these wonderful recommendations that you're putting forth. So I just want to make and emphasize how important the workforce issue is for the entire country, and especially as one thinks about, like we have for this sprint, long COVID, in ensuring that we are training and instilling that into our medical students, our residents, but also those of us and providing an education for them to provide quality care for all. Thank you.
Thank you, Dr. Martinez, for lifting that up as well. Wonderful. Great. So much appreciation again to the Healthcare Access and Quality Subcommittee. Thank you again to Dr. Putnam and all the members. Dr. Okafor, back to you.
Thank you, Madam Chair. And again, a lot of appreciation for healthcare access and quality for exceptional job done. Thank you. And with that, I would like to introduce our next subcommittee, and that is Structural Drivers and Xenophobia Subcommittee. I'd like to call upon Hye-Young Yoon to actually present excellent job your team has done. Thank you. Hye-Young, take it away.
Thank you. Thank you so much. I want to first express my deep gratitude again for another month of amazing and committed sprint that we did this month. So I want to express my gratitude to the members, Myra Alvarez, Sarah Bleich, Jessica Cardigan, Richard Cho, Jolinda Johnson, Victor Joseph, Octavio Martinez, Mary Turner, and Bobby Watts. I want to also just say that the ex officio members who joined us more recently really rolled up their sleeves and jumped right in. So really much appreciation. Can we go to the next slide? So for this month, we have 3 problem statements and various recommendations that fall under each problem statement. So let me run through the 3 problem statements and summarize, and we can dig into the recommendations. So the first problem statement is looking at various underserved and marginalized communities who are more likely to be exposed and got COVID, and long COVID have trouble recovering due to ongoing exposure, lack of adequate ventilation, or overcrowding in their housing conditions. The second problem statement is looking at the rise of xenophobia and the rise of anti-Asian violence, and talking about the Asian American and Pacific Islanders in the healthcare sector who are experiencing increased discrimination and harassment in the workplace because they're seen as transmitters of COVID based on their race and national origin. The third problem statement is looking at having the impact of having long COVID, resulting in outsized negative economic, health, social, physical impact on families and communities across the country due to a lack of robust safety nets, increased dependency on family members due to the prolonged illness, and exacerbated long-standing insufficient support and services to people with disabilities across their lifespan. So in terms of recommendations for the first problem, we recommend that the federal government should provide funding and guidance to ensure safe ventilation practices and evaluate air quality standards for public housing, shelters, and other publicly funded centers. Can we go to the next slide? For problem number 2, in looking at the rise of discrimination Asian American Pacific Islander healthcare sector professionals are experiencing, our recommendation is to build upon the executive order and the presidential memo that President has already issued to combat systemic racism. The federal government should work with public and private hospitals and the healthcare industry to address discrimination faced by Asian American Pacific Islander healthcare professionals. Can we go to the problem third? So we have several recommendations on the problem, the third problem statement. So let me go through them. So the first is that the federal government should work with Congress to pass the American Families Plan to ensure that working families and children, family caregivers have the support they need to go back to work, go to school, to recover from the pandemic. These family supporting policies include establishing a national paid sick leave, as well as paid family and medical leave standards, making child tax credit that was part of past COVID relief bills permanent beyond 2021, providing family caregiver tax credit for those who provide care to their family members, and building upon the fiscal year 2022 budget to request to increase the number of school nurses and professional counselors to support children in K-12 who have long COVID and children whose parents have long COVID. Can we go back to this one. For recommendation 2, similar to the working with Congress to pass the American Families Plan, our recommendation 2 involves the federal government working to pass policies to create and improve jobs and rebuild our communities and economy. These policies include passing the American Jobs Plan to create jobs in our essential infrastructure like care and climate, along with physical infrastructure. Ensure that the patients with long COVID have workplace protections by enforcing existing laws like Americans with Disability Act and Family and Medical Leave Act. Also to develop a long COVID job reentry program with an eye towards targeting those who have been disproportionately affected by COVID. Yes. In the third recommendation is to enhance temporary disability benefits to support minorities, marginalized, and medically underrepresented individuals with long COVID. In particular, our recommendations call for improving and expanding the current supplemental security income, SSI, Social Security disability insurance programs, including speeding up application processing time, removing wait periods before payment and coverage, reducing work requirements necessary to qualify, as well as including long COVID in the list of medical conditions accepted by Social Security Administration, and to include allowance for temporary, partial, or situational impairments as qualifying disabling conditions, and increasing benefits to the benefit level to 100% federal poverty level. Under this recommendation, we are also calling for the federal government to help adults with long COVID to learn about and navigate the Social Security disability benefit system and accompanying healthcare program. Also, the federal government should clarify its educational accommodations for those experiencing long COVID, including eligibility requirements for special education and related services, in addition to helping students and caregivers navigate the systems and programs that exist to support them. Lastly, the federal government should create an updated information materials to clarify that people who have faced financial hardship due to long COVID are eligible for rental assistance. I'll stop here and open it up for members or the subcommittee to lift up, amplify, and add anything I missed. If no one else wants to add, I'm going to turn it back to you, Madam Chair.
Thank you so much, Chair. You really quite comprehensive. Let me add my thanks as well for the great work. I really appreciate. I know we have ex officio representation in strength on this subcommittee, so a special moment to say thank you, of course, to all the ex officio members for all the hard work you're doing. Obviously, full task force members, but in a special moment to say thank you to you for all that you're doing and bringing to the work. The slate of recommendations presented from structural drivers and xenophobia is open for discussion and comment from anyone in the task force who isn't a member of the subcommittee, if you would like to raise anything. I do see a hand from Mr. Toronzo, please.
Thank you, Madam Chair. I just like to express my appreciation for the recommendations the subcommittee worked on. I absolutely agree that not only should we fund an increase of school nurses and professional counselors in K through 12 schools, but also building on that educational accommodations that could be provided to students that are suffering with long COVID. So I really appreciate the recommendations and excellent work. Thank you.
Thank you, Mr. Toronzo. Mr. Imperato, please.
Yeah, I just wanted to commend the subcommittee for the recommendations around making the whole federal disability benefit system more user-friendly for folks that are experiencing long COVID. There are lots of implications of those recommendations for the whole disability community, not just people with long COVID, but I think if you look at the history of disability policy in our country, oftentimes it's after a major influx of veterans with disabilities after a war that we see significant innovation and improvement. And I feel like there's an opportunity like that, given the scale of long COVID, for us to really try to improve the way services and systems are delivered in this country for people with all types of disabilities, not just people with long COVID. So very much appreciate your recommendations around that.
Ms. Johnson, please.
Thank you, Madam Chair. I just want to, as a follow-on from Mr. Imperato's comments, also highlight the importance for employers to recognize conditions, whether someone has a diagnosis of long COVID or not, if they have and are experiencing symptoms that require them to receive accommodations in the workplace. Employers are reminded that that is still a requirement. And I think the highlights done by the subcommittee on expanding protections really highlights that employers are perhaps not recognizing current protections and expectations under the law. So I really appreciate those comments in particular. Thank you.
Thank you. Thank you very much. Great. Seeing no other hands raised at this time, just once again, thank you. Very, very important, really important contributions for our conversation and interim recommendations and work this month. Thank you again so much, Ms. Yoon, and to all of your committee members. Dr. Okafor, back to you.
Thank you, Madam Chair. And again, want to express gratitude for a very peculiar subcommittee, our structure, driver, and xenophobia. You guys have done exemplary work, and I appreciate your recommendations. With that, I will move forward to introduce our last subcommittee, and you will, for those that are listening, you will also hear tremendous job they have done. And it is with great pleasure that I introduce Myra Alvarez. Myra, take it away.
Thank you, Dr. Okafor. I want to begin by thanking the members of the subcommittee, Andy Imperato, Octavio Martinez, and Vincent Toronto, as well as our ex officio members, Jolinda Johnson and Dr. Rachel Levine, and the full membership of the task force for their thought partnership, as well as HHS staff and interns for their great support. Just as a quick reminder, and in particular for those that are new to the task force, our subcommittee is created to explore how issues related to communications in all of its various forms and collaborations, both within the federal government and with external state and local partners, can contribute to a more equitable response to the pandemic and future pandemics. So as it relates to the issues of long COVID, PPE, therapeutics, and testing, we identified two overarching problems that we intend to tackle through our interim recommendations. First, as has been shared by both speakers and fellow task force members, there's a lack of an accepted definition of long COVID. There's also this limited availability of information because of that lack of accepted definition. And there's just a general absence of a common language to discuss long COVID. When you combine that with what we know is a fragmented and siloed healthcare infrastructure, even before the pandemic, that has led to increased bias, discrimination, hesitation, doubt, and heightened stigmatization by marginalized and minoritized communities. And this is occurring because of provider behavior, but it's also experienced by the patients living with long COVID themselves. The second problem statement, and again, this builds on previous comments by task force members, we identified that patients, providers, and communities disproportionately affected by long COVID have fewer workplace protections, as well as fewer employment opportunities that together result in lost pay, lost jobs, and compromised health. And again, this is impacting populations who are marginalized, minoritized, or medically underserved disproportionately. So knowing these are the challenges, we identified a set of recommendations to respond in both the short and long term. And we moved forward, so great. So in response to problem one, we have 5 recommendations. The first is really that the federal government provide resources and collaborate with community-based organizations and providers to specifically create a long COVID technical assistance center. A technical assistance center that would include a hotline for community members and other stakeholders that need to learn more about the condition, that are interested in learning more, that they can share their experiences living with long COVID or treating people with long COVID, and that they can be connected to local resources. This is in direct response to concerns that we've heard by people living with long COVID about not being believed, and the need to have these additional resources to build awareness, to build understanding, so that they can get the supports and services they need in their community. The second recommendation is along the same lines of building awareness. We recommend that the federal government execute a robust communications campaign, and that they do so in collaboration with major professional associations that, again, will build that awareness, will educate, and specifically solicit more data from the public on long COVID. The campaign would include efforts to reach marginalized communities, but also the healthcare workers that serve them. And we expect that the campaign be informed by stakeholders from diverse communities in order for the federal government to have a more comprehensive understanding of how long COVID is impacting specific communities. This dovetails incredibly nicely with what other subcommittees have put forward as trying to collect that information directly from people living with long COVID. The third recommendation would be the establishment of a federal advisory committee, specifically on long COVID. We expect that the advisory committee would be comprised of a majority of patients living with long COVID, but also external experts in researching and treating post-infectious chronic illness and their comorbidities, such as chronic fatigue syndrome, like we've heard before throughout today, especially from Dr. Whitfleet. But also that the committee include disability advocates, given so many of the parallels of the experience of people living with long COVID and people living with disabilities, having that perspective, that expertise is particularly important. The committee would then have the opportunity to influence federal response to long COVID as it works with agencies across the federal government. Next slide, please. And so continuing our recommendations in response to problem 1, we also recommend that the federal government create a public-private partnership to fund healthcare providers and community-based organizations serving communities most affected by long COVID. I think we have heard during multiple meetings of the task force that investing in local resources is a critical way to better reach marginalized and minoritized communities. So these funds would support local efforts to reach these communities with information, supports, and services regarding long COVID. It would also enlist the collaboration of philanthropy, our state leaders, and local organizations that together strengthen that national capacity to really support people living with long COVID. And then finally, in response to problem statement 1, we recognize the disproportionate impact of COVID-19 on marginalized and minoritized communities. And as such, recommend that the federal government lead the development of a long COVID health equity learning community infrastructure. And that it be done so in partnership with long COVID centers and clinics that are developing across the country, so that together we can research, understand, develop interventions, and treat long COVID. We know that there's a significant need to share information and resources amongst researchers and providers serving long COVID patients, but also amongst community members living with long COVID. So this long COVID health equity learning community infrastructure will facilitate those collaborations and exchange of knowledge between the centers and clinics and putting more information and power into the hands of people living with long COVID themselves. Next slide, please. So to respond to problem 2, we have 2 recommendations that seek to leverage the power of both communications and collaborations. So first, recognizing the complexity of long COVID and how it impacts every aspect of an impacted individual's life, the federal government should launch an interagency-led initiative that focuses on long COVID patients' rights and support services, such as legal aid, vocational rehabilitation services, housing, as well as occupational therapy and others. Through this initiative, the federal government would support programs that help patients with long COVID learn about and navigate these services so that they can get the support and care that they need to manage the impacts of long COVID. As was flagged earlier by our colleague, Andy Imperato, we have seen the challenges that exist for people living with disabilities in navigating their rights, navigating the very systems that are supposed to serve them. This interagency-led initiative will seek to minimize such barriers, given some of the valuable lessons that we have from people living with disabilities, and in trying to improve the care for people living with long COVID. And finally, the federal government should create a tip line for employees to address health and safety violations by employers. And this really is aligned with responding to problem statement 1 as well. It's another effort to collect valuable information from community directly in order to ensure that our federal response is targeted and as effective as possible. And in order to do this in a trusted manner, the tip line should provide a protected channel of communication for employees to express those concerns related to long COVID health and safety. And then that information that's collected will inform the federal response moving forward. Next slide, please. So we believe that the federal government has a unique communications and collaboration leadership role, particularly around the opportunity to educate and build awareness on long COVID, as well as the other challenges that we've seen. And in response to what we've put forward, we're looking forward to feedback and questions. But before I hand it over to our Madam Chair to facilitate discussion, I'll ask my fellow committee members to elaborate on anything I may have said.
Myra Octavia here. Yeah, great presentation. You've led the subcommittee wonderfully and great recommendations. I would just really highlight within those recommendations that we are really wanting to ensure, like the Technical Assistance Center and other recommendations, are providing support and services to all the different communities that we're talking about, including our providers, because they equally are looking for direction and assistance and wanting to do the right thing and ensuring things are being done from a quality standpoint and an equitable standpoint, so that this is really, as Myra has laid out, for all of us together to work on this very issue. So thank you, Myra.
Thank you. Great. Madam Chair, over to you.
Wonderful. Thank you so much, Chair Alvarez. Also want to extend my appreciation for your leadership on this subcommittee. I too, as you noted, welcome and appreciate the synergy between and across the subcommittees too, in terms of the recommendations and the alignment that is there. So thank you very, very much. The floor is open to any task force members who would like to comment on the slate of interim recommendations just put forth by Communications and Collaboration. Mr. Watts, please, the floor is yours.
Thank you, Madam Chair, and thank you, Ms. Alvarez, for your leadership and everyone on this committee. I just want to say I just really appreciate, both from the other subcommittee and this one, the importance of saying we have to help people navigate the bureaucracy of disability. We can have benefits, but if you can't access them because of barriers of understanding or bureaucracy, we are really reinforcing equity, because those who are most educated have the most time, spare time, and the political capital are those who will make their way through. So we have to reduce the barriers for everyone so that everyone in need can do that. So I really appreciate the attention to that from this committee and others. Thank you.
Thank you, Mr. Watts. Absolutely, that intentionality. Wonderful. Are there any other comments at this time? Another outstanding slate of recommendations from this subcommittee and from all the subcommittees. Thank you so much for the work this month to get us to this point. I note the time, let's call it 4:20 Eastern Standard Time. We will take a break at this moment. We will reconvene at 4:30 Eastern Standard Time. I'll see you back then. Wonderful. Welcome back, everyone. Captain Wu, there you are. Let me turn it over to you at this time to welcome public comment. Thank you so much, Captain Wu.
Great. Thank you, Madam Chair. As with all federal advisory committees, this is an opportunity for the task force to receive comments from members of the public. We received 3 requests to deliver comments. First, we will hear from Mr. Michael Sieverts from the Long COVID Alliance. Please go ahead and unmute yourself if you are on Zoom, or star 6 if you're on the phone. Mr. Sieverts, you have 3 minutes, and please proceed.
Hello, and thank you. I'm grateful to have the opportunity to speak today. I'm here as also a long COVID patient. Like Dr. Gage, who spoke earlier, I'm in my 15th month of this. And there are really just 2 things I want to mention, really just to amplify things that have been said or mentioned earlier in the meeting, but a couple of things I want to bring out more fully. First, on the testing issue, the access to tests. I think Dr. Gage said, and others have said, especially for people in this first cohort, who were back in March when testing was really sporadic, access to testing was hit or miss. Another reason that is incredibly important now is that the research studies at NIH and other organizations often require a positive test for enrolling people in the studies. So whatever disparities occurred in the testing phase have the potential to be carried through the research phase. And that I think you all know better than most how much that may limit the applicability or the relevance of the results of the research. So that's the aspect of the testing issue I wanted to amplify. And then just the second issue is earlier, particularly after Dr. Gage spoke, there was some discussion of the mental health aspects. And I will just say that that issue is probably even more complicated than it may seem. I say that because of the neurological impacts that COVID has. I am someone who is living with those neurological impacts. And so the fact that it's this emotionally challenging experience at the same time that your brain is not working right makes it a doubly challenging mental health adventure. And I think that, very often when I read about the mental health aspects of COVID, it is presented simply as, oh, it's so hard to be dealing with long COVID. Yeah, it's hard, but then there are very real neurological impacts that affect, cognition, et cetera. And that is just a complicating factor in this whole awareness and understanding of what's going on to the people who are living with long COVID. So those are my 2 points. I really appreciate the work you're doing. I'm very glad to have this opportunity to speak.
Thank you, Mr. Sieverts. Next, we will hear from Dr. Harold Schmidt from the University of Pennsylvania. Dr. Schmidt, you have 3 minutes, and please unmute yourself and proceed.
Thank you very much. Yeah, my name is Harold Schmidt. I'm an assistant professor of medical ethics and health policy at the University of Pennsylvania. I want to congratulate the chair, the task force members, and the staff again for your incredibly important and inspiring work. And I'm very grateful to have the opportunity to provide brief comments now on 2 points that I think stand in direct continuity with today's discussion and are of central relevance for the task force ongoing work on the federal crisis standard of care. And they relate to major new evidence and the importance of procedural as well as substantive principles. So first on new evidence, emphasizing and underlining equity concerns that colleagues and I expressed earlier, there are now 3 major studies that quantify inequitable outcomes from using the SOFA score in combination with the widely adopted triage framework. Specifically, Deepshika Sharan Ashana and colleagues analyzed data of more than 100,000 patients at 27 hospitals in the US, and they found that, quote, 81.6% of Black patients included in lower priority crisis standard of care categories, and 9.4% of all Black patients were erroneously excluded from receiving the highest prioritization. The SOFA score without creatinine reduced racial miscalibration, unquote. So what this means is that in practice, under severe crisis conditions, a large number of Black patients would die by being denied ICU care despite good prognosis. And a study published just last week by Dwight Miller and colleagues directly confirms this. What they did is that they used the eICU database and analyzed data of more than 95,000 patients admitted to more than 200 ICUs in more than 100 hospitals, and found that Black patients were structurally disadvantaged as their likelihood to die was overestimated. So under standards adopted by hundreds of hospitals across the US, 15.6% of Black patients were misclassified under severe shortage conditions from the highest to the second priority. And a third study that's about to be out and that I'll share separately directly confirms these findings. The new evidence also raises important questions about substantive and procedural elements in federal guidance. Importantly, the underlying triage model used in these studies has been revised substantially first in December 2020, including dropping the use of SOFA. However, the risk is that in hospitals across the country now, earlier versions will simply be filed away as is for future use, and there's no clear incentive at this point to make further revisions. So a clear benchmark statement by the task force on the use of SOFA and related measures, including ideally with recommendations for at least a core set of nationally uniform elements, such as the impermissibility of categorical exclusions and of racially biased frameworks, will hence be as critical for practical orientation in future pandemics as for the historic record. And substance aside, procedural guidance is also urgent. At the peak of the pandemic last year, Gina Piscitello and colleagues found that there were just 26 states that had publicly available crisis standard of care. And so a simple but clear and important recommendation would be to require all hospitals with ICU facilities to register publicly with HHS first, whether or not they have triage guidelines, and second, if so, to provide copies of all iterations in a timely manner. And the same should then be required for any state-level triage guidance, and developers of model guidance should likewise be actively encouraged to share their frameworks in this way. So to sum up, we now know that the designs of widely adopted triage guidelines enshrined major inequities. Substantive and procedural recommendations by the task force offer a unique opportunity to set the historic record straight and to enable a more equitable response in the next pandemic.
Thank you, Dr. Schmidt. Our last speaker is Ms. Riva Singh from the American Academy of Physical Medicine and Rehabilitation. Ms. Singh, you have 3 minutes, and please unmute yourself and proceed.
Thank you for your time today and the opportunity to speak, and most importantly, your attention to this issue. So many of the recommendations that have been made today would be really helpful, and I'm grateful to have heard them, and I hope that they are applied. AAPM&R represents over 10,000 physiatrists or physicians focused on physical medicine and rehabilitation nationwide. And I'm here to ask you to address long COVID as the crisis that it is by working with agencies across the federal government to create a comprehensive national plan that invests in healthcare infrastructure and ensures equitable access to care, not just to clinical care, but to other resources such as education, work accommodations, and disability evaluation and benefits. Our members have been opening post-COVID clinics across the nation for the past year. These clinics are multidisciplinary and are an attempt to serve as a one-stop shop for patients with long COVID to see multiple physicians, therapists, mental health professionals, and sometimes social workers. This is to help them address their illness that affects multiple organ systems and various factors of their day-to-day lives. These clinics aim to provide comprehensive and streamlined care so that individual patients are not left to coordinate their own care by juggling multiple referrals. That can be especially difficult for somebody experiencing debilitating symptoms, which is true for many long COVID patients, as well as the disability and complex illness population before long COVID. Currently, these clinics are primarily opening in academic medical centers, but such clinics need support so that they can be accessed by all patients across the nation. AAPM&R has gathered 26 of these post-COVID clinics to discuss best practices, patient access barriers, and to draft and disseminate clinical guidance directly to the bedside as soon as possible. I'm urging you to recognize long COVID as a crisis of the pandemic. Of course, AAPM&R recognizes that acute COVID is still with us and likely to continue. However, long COVID is well underway, as we've been hearing today, with some people suffering for a year or longer. The conservative estimate that's coming internationally is that 10% of people who are infected with COVID-19 will experience long COVID symptoms. That's currently over 11 million people in the United States. And this 10% is of the entire COVID population, not just those who had severe cases, were symptomatic, or received a positive COVID test. As has already been discussed, there are many reasons that people may have not received a positive COVID test or an antibody test. In addition to a national crisis plan, I'm asking for an immediate public statement addressed to this growing patient population to let them know that they are recognized and that help is on the way. This population is currently being dismissed, like many chronic illness patients have been, because their symptoms may be vague and variable, because this illness is unknown and new, and again, because they may not have a COVID history in their medical record. The issues of long COVID, as we've been discussing all day or all afternoon, are complex and wide-reaching. Similar to Ms. Alvarez's subcommittee's recommendations for a federal advisory committee and an interagency committee dedicated to patients' rights, AAPM&R believes that a diverse body of experts from across the government needs to be working together and with the public to ensure that efforts are not being duplicated and that there are no further gaps in equitable access to resources. Again, we think that a national crisis plan would be the most effective and efficient way to ensure this. Thank you again for all that you do, and AAPM&R is a resource to this task force, and we hope to continue working with you.
Thank you, Ms. Singh. This concludes public comments. Back to you, Madam Chair.
Thank you so much, Captain Wu, and thank you to everyone for providing public comment. At this time, we will return to the slates of interim recommendations presented by each subcommittee earlier in our meeting and take up voting on each interim slate in the order in which they were presented to the task force. So we will first consider the slate of recommendations offered by the Data Analytics and Research Subcommittee. Do I have a motion from a member?
So moved.
Thank you so much.
Second.
Thank you so much. Any further discussion? Hearing none, please, I will call now for the yay votes. Please signal by raising your actual hand. Should you vote yay? Yays, please. I'll take one moment for the contractors. Thank you very much. Any nays? Any abstentions? All right, thank you so much. I vote yes, that motion carries. We'll turn now to the slate of recommendations put forward by the Healthcare Access and Quality Subcommittee. Do I have a motion?
So moved.
Thank you so much. Ms. Turner, second.
Second.
Thank you. Any further discussion? Right, hearing none. Yays, please. Hold for 1 second. Thank you so much. Nays? Any abstentions? Thank you so much. I vote yes. It carries. Turning next to the Structural Drivers and Xenophobia Subcommittee Interim Recommendations. Do I have a motion to move that forward?
So moved.
Thank you so much. May I have a second?
Second.
Thank you so much. Any further discussion? Just want to note for the formal record that we will update the language to reflect Asian American, Native Hawaiian, Pacific Islander across those recommendations, A and HPI. Thank you so much. At this point, yeas, please. For 1 second. Good, thank you so much. Any nays? Abstentions? I vote yes, that carries. Our final set of recommendations was brought forth by the Communications and Collaboration Subcommittee. May I have a motion, please?
So moved.
Thank you. Is there a second?
Second.
Thank you. Any further discussion? Okay, thank you. Hearing none, we can proceed to voting. Yeas, please. Hold for 1 sec. Thank you. Nays? Any abstentions? All right, thank you so much. I vote yes, that carries. Congratulations, Task Force. Once again, an incredible slate of recommendations. As far as process, these recommendations that have been advanced today will return to subcommittee for continued review, will be finalized before final presentation in our subsequent and forthcoming report. So let me just take a moment now to offer my thanks as we get ready to conclude our 5th public meeting. I'm really grateful to everyone we heard from, of course, in public comment, everybody who has joined us today in the live stream or who is watching this later on the recorded line. Special thank you to the subcommittee chairs, each and every one of you, as well as each and every task force member, generating incredibly thoughtful, timely, highly relevant, and actionable recommendations for our deliberation and consideration. Many guest experts we heard from 2 today. A special thank you to them for joining with us, as well as to all of the many experts who joined the subcommittees in the sprint up to the work and who have joined us in stakeholder roundtables, making sure that the work can be informed by many different voices and perspectives. Thank you, Dr. Okafor, our Executive Director. Thank you to Captain Wu, our DFO, the entire federal staff team. It takes many people to support this work, so deep gratitude. Moment of thanks as well to our ASL interpreters today. Our next meeting will focus on future pandemic preparedness. So stay tuned. The date and time are provided in the meeting notice that's published in the Federal Register. That notice is also posted on the task force website. So once again, thank you everyone for joining. Please be safe. I'll turn it back over now to Captain Wu.
Thank you, Madam Chair. Meeting adjourned.
Thanks, everybody.
Thank you.